Next, I'm going to be presenting something, some of you may have seen this before. I've been doing this for about 5 years now, and dorsiflexory wedge osteotomy, the first metatarsal, even though intellectually it's a very straightforward procedure, application-wise it can be very challenging. Someone told me early in my career that a Javara closing-based wedge osteotomy with 2 screws is one of the more difficult procedures that we really do. And I kind of winced at that a little bit, but the reality is it's very true. The geometry of getting in the 2 screws, the fragility of the hinge, and trying to keep everything in the right plane can be quite difficult. And though the DFWO may not be quite as difficult in the traditional way that we used to do it, getting it stable, fixated, and getting it to heal without complications could be quite the challenge. So I'd like to offer you a different twist and flavor on how to do this that may be successful for you. The typical indication for DFWO for me has been rigidly plantar flexed first ray, and this may show up as a cavus foot. Frequently for me it shows up as peroneal tendon pathology. People have a chronic tear, peroneus brevis, peroneus longus, and what I really have learned after the first couple of years of practice is if you don't really address the cavus structure of the foot, if it's of any significance, your peroneal tendon repairs are kind of doomed to failure. I do a pretty good job on this most of the time. I actually have a lady right now, and I can't blame this on anybody else. I looked at it, I said, she's got a little bit of a cavus foot, it's not that bad. I had done a peroneal tendon repair on her. She came back about 3 years later with recurrent symptoms. I again looked at it, did it again. And this time when she came back, I said, I guess maybe your first ray is more plantar flexed than I think it is. And I even sent her to Brodsky for a second opinion, just trying to make sure that I'm not missing something, because it's not that dramatic when you looked at it. But if you do the Coleman block test on these people and you really look at where their heel is, it can be a really great eye-opening experience to expose how much effect there is from that first ray. Even if the rear foot's in neutral and you're looking at them with the forefoot loaded and you may not really feel, it's like, okay, the first ray's a little plantar flexed, you really can expose how much of an influence there is with this. And you have to realize they're going to hit and heel strike, they're going to pronate, and as they go into full forefoot loading, whether it's functional or rigid structural, as that first ray loads, it kicks the foot back into supinatus and it puts more strain on the peroneal tendons. Finally, some of them will present with sesamoiditis, with or without a bipartite or a previously fractured sesamoid. And you may need to raise the first ray to control this. So what do we talk about if we're talking about an ideal osteotomy? Well, obviously it's going to have good stability. It's going to be in a metaphyseal location, so it's got good healing potential. It's going to require minimal dissection. It's easily fixated, and it's healed by Friday at 5, right? Well, that's the ideal. It's not going to happen, but we're aiming to try to get as close to this functional ideal, this physiologic ideal as we can. Well, historically, when I came through training, this is how we were trained to do a DFWO. So you would expose essentially the entire first ray. You would kind of deglove this entire diaphyseal area, and you would make this long cut that almost started kind of behind the joint here and went all the way down to that plantar proximal corner, because the goal and idea was you were making this as parallel to the weight-bearing surface as you could get it. The reality was that by the time you got this piece of bone out and you went to fixate it, the difficulty was frequently the tip of this screw would track down the inside, it wouldn't compress, or worse yet, you'd break the hinge, and you were left with this unstable mess to try to fixate and repair. And then you've got this whole entire area that's been degloved of the blood supply of the periosteum. So after struggling with this for what I hope was the last time, I kind of sat down and said, what would be a better way to do this? So the difficulty were these things. So the solution, the postulate that I had was, if we can make the osteotomy more metaphyseal, if we can improve the overall stability of the fixation and decrease the amount of dissection, then it would make sense that these would all be good things. So I really started to play around with this, and I had a patient come in who really had a bad plantar flex first ray, and I said, I think this is a good place to try it. So you can look at this and say, is this a horrible cavus foot? No. But it is a neutral to supinated, kind of a milder cavus. You can see all three facets of the posterior facet. You can see that there's a little bit of break in the simul line here. But clinically, this patient had a much more significant plantar flex first ray. So my postulate was, if we can keep the osteotomy diaph seal, give it just enough room to get your fixation in, minimize the periosteal stripping, you'll quicken the procedure, you'll decrease the OR time, and you'll make this a better healing potential osteotomy. So obviously fixation is dealer's choice. You can use just about anything. Don Green showed some offset staples. That certainly staples are a viable alternative here. Little mini plates are good. K-wires, pins, whatever you like. I generally use a little 2-hole plate, and I'll show you some good things and some bad things about this and make some recommendations. So this was the first one that I ever did. So we went ahead and marked out the first ray, made this incision, which is about twice as long as it really needs to be. Got right down on, peeled the periosteum back only where the osteotomy is. You can see that the joint level is right about here. And here's where it kind of gets kind of cool, because your fixation defines your osteotomy, or vice versa, depending on how you want to look at it. So I said, as Dalton taught me, I said to myself, self, if you want this to work, you need to know where your fixation is going to anchor in on the proximal side before you make the cut. So whether that's just marking it out with a marking pen, or as I did here, go ahead and put the first screw in with the 2-hole plate. Then I spun the plate back out of the way, made my cut distal to that screw, and then rotated the plate back around. You can see the cut, the screw, the joint, and then we offset drill the distal hole to generate compression, and it sucks this thing up like there's no tomorrow with minimal periosteal stripping. This is 3 times as much periosteal stripping as I do now. I literally will just kind of make a little nick in the periosteum, go straight down, just reflecting it here and on the other side. And here you can see offset drilled. Look how tight the dorsal part of that osteotomy is. And if you need to feather it or whatever you need to do, that's great. But this is stable in the sagittal plane. It's reinforcing it. It's in the metaphyseal area. And I'm done in about 45 minutes. And I am not the fastest guy in the world. But you can see, first ray is now up. Everything's more relaxed. This isn't a full weight bearing view. This is fairly early post-op. But you can see that you really can't see, as JR was talking about yesterday, at initial post-op or at 6 weeks, ideally we want this to look the same, so you're getting primary bone healing. So here's the next case that I ran into. I had this guy, he's a 49-year-old guy, he works at Walmart, he's on his feet 24 hours a day practically. 15-year history of diabetes with peripheral neuropathy. He had a chronic sub-1 ulceration. I had made him multiple pairs of CMO orthotics to try to offload and protect this area. Short of putting him in a boot with a 2-inch thick sole completely cut out into the area, I could not adequately offload this thing. I think somebody else had done a previous gastroc recession on him. But I had been over a year of conservative management with orthotics trying to keep him healed. And it was, if I didn't see him every 3 weeks, the ulcer would break down again. So you can see here, you can see the cavus foot structure. If you look, here's the sesamoid apparatus, and you can see that that first ray is below the axis of the second metatarsal behind it. So here he is, his initial post-op, and I'm pretty proud of myself, patting myself on the back about what great thing I did. I will give you a clue in advance what happened here. Got a neuropathic patient. We've got a titanium plate and screws. These are 3.5 millimeter screws. And we all know that they have peripheral neuropathy not only in their feet, but between their ears. And what happened was I got him out of a cast. I felt really good about the stability of this. I put him in a boot at about 3.5 weeks, and I said, okay, you can walk on it, activities of daily living in your boot. Well, there he is at the going into the boot, and then he comes back at 7 weeks. He says, hey, doc, I've been doing really good. I've been walking 3 miles a day for exercise in my boot, keeping my blood sugars down really good. You can see the broken screw. Fortunately, because the osteotomy was intrinsically stable, the plate was still relatively locked to the dorsal cortex, it didn't shift a whole lot. So you can see that there was a little buckle back here. You can see a little more periosteal reaction as a result. The joint was not affected. It healed uneventfully. The ulcer completely resolved. So I learned something. When I did his other foot, I took a 1/3 tubular, large conglomerate company name plate. I think I used whatever the smallest plate was, 4-hole, 5-hole. I cut it down to a 2-hole plate. But these screws have a core diameter of 2.9 millimeters instead of 2.4, 2.5, and they're stainless, which has a much better cyclical loading than titanium. And he went on to heal this side with absolutely no complications and no disruption. Next patient, 56-year-old male. This guy came to me. He had had 2 previous surgeries for repair of chronic peroneal tendon tears, one with removal of an ossicle, one with, I think, allograft reconstruction. But you can see here what he looked like. And again, you look at that x-ray and you say, yeah, it's a plantar flex first ray. Is it a massive cave's foot? No. But if you look at the talar first metatarsal axis, the talus is lateral to the first ray. And I had him stand down. I did the Coleman block test on him. I said, 2 previous surgeries. I want to make sure this works. I probably may have done a little more than I needed to, but he's done extremely well. We did a Dwyer, DFWO. It took me longer to tease out the chronic tearing of his peroneal tendon, to revise the peroneal tendon, than it did to do all the bone work put together. But he has done just exceedingly well. No further problems, even though he had had 2 previous failed attempts at chronic stabilization of the peroneal tendon tear. So the results is the peroneal pathology was repaired and resolved, and he's had no further need for additional cave, because I thought I might have to go back potentially and do a colostomy on him if it wasn't quite enough, but it was never necessary. Final case, 31-year-old female. She presents with chronic peroneal tendon tear, obvious plantar flex first ray. So again, you see this cavus foot. You see the talar first metatarsal axis, which is divergent. That Meary's angle is way off. Again, you can see the talar axis is slightly lateral. You got maybe a little bit of metaductus thrown in there as well. And same type approach. 2-hole plate. Put the proximal screw in, spin it out of the way, cut the osteotomy, spin the plate back around, offset drill your distal hole, pull it up, and you're done. So in summary, I offer this to you as a different approach technique. It works really well by using a standard 1/3 tubular locking plate. It's very cost effective, it's very reasonable, it's very inexpensive. Because you've minimized the dissection, there's very little swelling with these. I walk them typically at about 3.5 weeks if I feel like my plantar hinge is good and the bone quality is good when I get those screws in there. You don't need to fixate across it. If you wanted to use staples here, you certainly could put cross staples in at least 60 degrees apart, one dorsal, one more medial, plantar medial, and that certainly would be adequate as well. But it provides intrinsic stability with an excellent healing potential, because we're in that metaphyseal area of the proximal metaphysis of the first metatarsal. So I offer that to you. Hopefully it's of some value to you when you look at some of these patients. And again, in my hands, this has been great for people with these chronic peroneal tendon tear problems, when we really look at their foot globally to say, okay, before I repair these peroneals, am I going to be able to say that I feel solid and comfortable that we've offloaded the tendon and we've taken away the underlying deforming force off this tendon that we're repairing? Or are we just repairing something that we're going to end up coming back and doing something to again down the road, because we haven't really managed the entire global picture of the deformity of the foot? Thank you very much.